Okay,
right to the
so I think Dr. Patterson, we can start right now. So, Bismillah ar-Rahman ar-Rahim, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I would like to welcome you all tonight. We will start our series of events after Eid. Eidkum Mubarak. My name is Halima Abu Kaboos. I am a diplomate of American Board of Pediatric Dentistry. I'm currently working as a consultant in the Ministry of Health in the Eastern Province of Saudi Arabia. First of all, I would like to thank the Saudi Society of Pediatric Dentistry and also Kunuz Ritaj for their collaboration to organize multiple successful events, including tonight's event. And also to welcome Dr. Kimberly Patterson, our guest speaker from US. Dr. Patterson received her bachelor degree in dental hygiene in 1988 and her master in anatomy microbiology in 1994, and then her DDS in 1997 from Baylor College of Dentistry in Dallas, Texas. Then she completed her residency in pediatric dentistry at the Louisiana State University School of Dentistry and Children's Hospital in New Orleans, Louisiana, 1999. Dr. Patterson was a consultant to the cleft lip and palate team at the Dill Children's Medical Center of Central Texas. Dr. Patterson's research interests include lesion sterilization and tissue repair, applications of mold restoration, laser, and pediatric dentistry. Dr. Patterson is a board-certified pediatric dentist. Tonight, Dr. Patterson will highlight the contemporary challenges for patients with special healthcare needs. We'll leave all the questions till the end. I would like to welcome Dr. Patterson. You can start and share your screen, please. Thank you so much, Dr. Patterson, for accepting the invitation and share with us your knowledge and information for tonight's event. Thank you.
Dr. Abu Kaboos, thank you so much for that very kind introduction. I truly appreciate the invitation to be here and speak with everyone. I look forward to discussion at the end of the presentation. And again, contemporary challenges with patients with special health care needs. There are several out there, and hopefully we'll touch on a few of those as our discussion and time together progresses. And for some reason, there we go. I thank you to the Saudi Society. I very much appreciate the opportunity. Dr. Al-Johar, President of the Saudi Society of Pediatric Dentistry, Dr. Al-Malik, the Chair of the Saudi Board, and of course, Dr. Abu Kaboos, our moderator for the evening. Thank you so much for your time today. These are bluebonnets, the Texas state flower, and I start our discussion tonight with the Texas state flower. I was born and raised in Texas. Hopefully that gives you a reason for understanding why I speak like this and for why there is no way that I can change my accent. I will try not to throw too many Texas vernacular into our discussion tonight, but I did want to share a little bit of my home state with you all. And these are my two fur children and feathered children. I actually have a cat and a duck that do live fairly harmoniously. And for anyone who has taken the board exam, you might have heard the rumor of the board examiner that has a duck that laid an egg while we were in Dallas for the board exam. And we had to evacuate for a hurricane when I lived in South Carolina. So this is the infamous duck that laid the egg in the Dallas hotel while I was there to be a board examiner. So a little bit of information about me, even though we're far away. I think it's important to connect on a personal level so that we all can understand how to relate to one another. Special needs was such a broad topic, and what I tried to do with this topic was to distill it down into some bite-sized chunks that we could get through in the allotted time frame. And those bite-sized chunks that in my mind made somewhat a little bit of sense was to discuss, number one, that there are multiple conditions with special healthcare needs presently that with the advent of contemporary medicine is increasing the longevity for many of our patient base with special healthcare needs, and how we need to modify our particular treatment and transitional care for those patients. As a former dental hygienist, preventive dentistry and preventive measures is very near and dear to my heart. And I know tonight we might have a varied audience of not only pediatric dentists, but also assistants, dental hygienists, maybe some general practitioners as well. So I wanted to discuss a few thoughts about preventive measures for our special healthcare needs patient base. A topic that might not come up that often when we discuss special healthcare needs is orthodontics. And we want to just touch on a few little items and things so that we can broaden our mind and think about the opportunities for orthodontics in this particular patient base. And the last discussion that we'll have is the contemporary comorbidities for things that are affecting those with special healthcare needs and in light of our present situation. I wanted to go ahead and disclose the resources that I used early on in the discussion. As Dr. Abu Khawas mentioned, I'm with the Board of Dentistry. I'm a board certified pediatric dentist. I'm on the exam committee, and I'm also an educator. So I use the American Academy of Pediatric Dentistry's reference manual. I use all of the reference materials from the American Board of Pediatric Dentistry reading list to compile some information to help us with our discussion tonight, and also drew from some as contemporary of references as I could find for our discussion as well. And again, I appreciate the opportunity to work with you all because it was very interesting to go in and research from the Saudi perspective the efforts with special healthcare needs patients in your location as well. I think the oldest reference that I'm using here is from 2003. So just wanted to start with some references and my working definition of special healthcare needs. I go by the American Academy of Pediatric Dentistry's definition that is very broad and encompassing. I know that there are many other definitions out there that are much more of a fragment of this vast definition, I should say. Physical, developmental, mental, sensory, behavioral, cognitive, emotional impairment, and anything that limits the condition of the patient. They can be congenital, you're born with it, developmental over time, or acquired through things like accidents and whatnot. Also, CODA, which is the accrediting board for dental schools here in America, they also have a wide range that they want the students to be exposed to, and they also include the vulnerable elderly in their definition of special healthcare needs. So that is our working definition that we're going with. Again, when you're handed the discussion of special healthcare needs, it can go in many, many tangents. So we're going to try to narrow things down just a little bit for our discussion tonight. To start off with just some facts, because we all need to have some facts before going into a discussion. About 15% of the general population in the world are affected by special healthcare needs. Personally, I think that might be an underestimate, but from all the resources I was able to pull, 15% seemed to be the median. And then within that 15%, a much smaller portion, 2 to 4%, are very severely limited in their presentations with their disability. What does that mean to us as practitioners? That means we have patients in our base that are going to require continued healthcare support throughout their lives. They require some regular medical evaluations. Medications can change, medications can come and go. Severity can be on a spectrum. Home-based support, so we have to not only work with the patient, but we also need to educate our caregivers, our parents, any type of staff members at facilities, so that they understand how they can support our patients with special healthcare needs. And this often involves extra equipment that the patient might need. Equipment incurs a vast financial encumbrance for our families. So we have to be cognizant if we're recommending things for the family or the care team to use, that we do take into consideration that financial need as well. I love this photo. I think that's beautiful. In the research, I wanted to see specifically what we needed to address tonight as far as the disabilities within your particular area. And the three that I saw that were the top as far as frequency were cerebral palsy, developmental delay, and issues arising from traffic accidents. Gaps in care were acknowledged to be access. And I think, honestly, these gaps in care are ubiquitous. I think they're global. I think we all have to understand that we all have this going on everywhere. Access to care is critical everywhere. Service coverage can be a challenge. I know here in America we have the Medicaid system, but we do have children, pardon me, within that gap of that can be covered by Medicaid insurance, but then are not eligible for Medicaid insurance, and their families can't afford conventional insurance. So there's that gap in service within our particular patient base, and also quality of care. Quality can be challenged from just an understanding of basic dentistry, but it also can be challenged by the behavior presentation of the patient base in and of itself. What does this mean to us? About 95% of us as pediatric dentists are going to treat patients with special healthcare needs. We welcome them into our practice. Sometimes we keep them a little bit later past our typical date of getting them transitioned to an adult dentist. But fewer than 10% of general practitioners, at least here in America, treat patients with special healthcare needs, and that causes a great gap and problem with our adolescents that are transitioning from pediatric dental care into adult dental care. It's much better if we can get some of our general dentists on board to help us out and make sure that our young ones have a good transition into more adult-based dental care that results in more complicated treatment plans, etc. So the transitional dental and even the medical care is very highly variable for some of these patients that manifest special healthcare needs. This is a non-comprehensive, but as much as I could put on a slide that wouldn't get too busy, but it's a review of some of the issues that can result in special healthcare needs. This is actually a list that I use with our dental students to get them ready to understand what the diversity and the scope of special healthcare needs is all about. I'm a very simple-minded person, and I'm also very simplistic when it comes to my educational standpoint, so I try to break things down. If you've noticed, it's all by the alphabet, so I have A, B, C, D, got all the way down to F for neurological, and then added some extras, but I try to work with the dental students to make things understandable and relatable, and that's what this list is all about. We're going to talk about longevity. That was our very first bullet point for learning objectives. Longevity plays a critical role in many of the conditions highlighted in red on this screen. We're seeing patients affected by these particular issues much later into life than previously recorded. So it's important for us to understand, number one, how to care for our patients that are affected by these issues, and then also what to look out for as the child and patient progresses in age, and make sure that we're equipped to handle what comes our way, or make sure we have some system in place such that we can transfer that patient to another care provider that can handle their conditions better than we, and recognize our limitations. Speaking of longevity, one of the factors on the list was leukemias, blood dyscrasias, anything, cancers that affect our young ones, which is always a sad situation. But the beautiful thing now is that so many of our young ones affected by leukemias and blood dyscrasias are living longer and more productive lives because of contemporary medicine. So we're going to be seeing those patients in our practice. As they age, the different kinds of cancers change a little bit, because earlier, our younger children are more affected by your leukemias, brain issues, brain tumors. And then as they get older, we need to start screening for thyroid cancer. Always palpate the thyroid gland in the front of the neck when we're doing our exams for our young patients. Melanomas, skin diseases, skin cancer, and also skin diseases as well. But I thought this was an interesting approach at how we need to be cognizant within our own practices. Difference between childhood and adolescent cancers. Younger patients are less often affected by cancer, thankfully so. We don't want anybody affected by it, but at least birth through age 4 out of 100,000, you may have 16 that are affected by a blood dyscrasia. That does rise as the child ages, and then over the age of 40, the incidence is much higher. And one of the articles that I read linked that back to ionizing radiation and exposure to ionizing radiation. One thing we do in our dental office is take dental x-rays. So we need to make sure that we are protecting our patients with lead aprons, with a thyroid collar that does cover the neck area and keeps the radiation out of the thyroid gland as much as possible. It's very vulnerable to radiation. And then the concept of a LARA, which is as low as reasonably achievable. If your assistant or a hygienist or the dentist takes a radiograph and maybe it's a little bit blurry, but you can see what you need to see, it's not wise to take a second radiograph just to get rid of the blurriness or just to get what you think is a better image, unless it might change your treatment plan. We don't want to irradiate our children any more than we really should or have to. The after effects of radiation, chemotherapy are going to change things as well. We have to be wary of mucositis. Their gingiva might be friable. They might be very sensitive to tartar control type toothpaste that have an ingredient called pyrophosphate. And just with the simple addition of the word pyro, you can understand that it does mean hot, spicy. That often does not go very well with tender mucous tissues. Neurotoxicity, where the nerves are actually damaged to the point that they can feel pain when it's not from an odontogenic source. It can mimic a toothache, even though there is no rationale for the tooth to have any discomfort associated with it. Tooth abnormalities, as you can see from this photo, we have some little microdont teeth. You can have agenesis or non-formation of teeth due to the chemotherapy or the radiation, or you can have teeth that are misshapen. They're still there, but what's going to happen now? The architecture of the gingiva changes. You're going to have more areas for plaque retention and plaque traps that can lead to caries, that can lead to periodontal issues. It's also going to cause issues with occlusion. Anytime we start thinking about doing any orthodontics, we have to be cognizant of that as well. And also, like I said, the gingival architecture, make sure that it's fairly self-cleansable, or take some precautions to teach your patient how to clean the areas themselves. And I just put in some little fun facts that not fun because it's talking about radiation, but radiation kills the cells just within that field of radiation, while chemotherapy more systemic, and that's what causes our issues with our little microdont teeth, typically with our cancer patients. What does this mean to us? We just talked about orthodontic issues that can be caused from a myriad of problems, just microdont teeth or teeth abnormalities notwithstanding. Joint effects, xerostomia is critical. If they have radiation therapy to the head and neck area that affects their salivary glands, obviously xerostomia is going to lead to increased caries risk, increased caries incidence. That can result in some very complicated treatment plans, oftentimes way over the scope of pediatric dentistry as we know and typically practice it. Stainless steel crowns to be used on primary but also permanent teeth as a means to save that tooth structure in its place. Various patients are going to require some early screening. We know that our Down syndrome patients are very vulnerable to periodontal disease earlier in life, but also they are susceptible to a variant of a leukemia that we need to screen for in their earlier life. Gingival hyperplasia that is not due to some type of an anti-seizure med, and most modern medications do not result in this gingival overgrowth. Radiographically, if you start seeing periapical lucencies, take a step back from that image. You'll note some other interesting artifacts all over the film. And these are actually demonstrations of leukemic infiltrates within the gingival tissues, and then also within the bony architecture of a patient. These are two different patients, but of patients with that are manifesting with a blood dyscrasia. So even in our routine radiographs, we might see some things that help our patients to understand that they need to seek professional help outside the dental office. Even though a child patient has been treated for some type of blood dyscrasia, they can go into a remission, which is a great time. They're disease-free, but they can relapse. And that is something that we as oral health care professionals need to be cognizant of so that we can do a really good and thorough job of checking out the patient, trying to rule out any rationale why they have the gingival presentation as shown here in this photo, why we're seeing some different artifacts within the film itself, and putting together a picture so that we can best direct these patients for appropriate care. Another sad fact about our special health care needs population, they are more subject to abuse and neglect as well. And so as we're conducting our examination of our young ones and our patients as they age, we want to be looking for those areas that could be a non-accidental injury. The safety triangle is something that I like to teach to our dental students and also our pediatric dental residents. Because we are dentists and experts in the head and neck area, I want them to check that area between the ear down to their top of their arm or clavicle bone, and then back towards the back of the neck. That typically is an area that a young one or an adult person is not going to harm themselves in an accidental injury. So that's an area that we do want to be cognizant of with our special health care needs and any child as far as that goes, just to make sure that they're in a good home life situation. That was an intro into my favorite subject, which is prevention. And again, being a former dental hygienist, it was always fun to try to figure out ways to assist patients with their own home care. It becomes a little fragmented when you have a special needs population, because oftentimes it's not the patient that you have to instruct on the home care of the patient, it's the caregiver. So for toothbrushing, these are just some thoughts that I had put together for patients over the years. For those that have joint issues, can't really hold on to a slender handle of a toothbrush, take a tennis ball or any kind of a hollow rubber ball and cut 2 slits, slip the handle of the toothbrush through those slits, and it allows the patient to grasp the toothbrush handle by the ball, and they don't have to close their hand down so forcefully. So even for our older adult population, this is a handy trick to know. This on the top right side is what we call a pool noodle. And if anyone has a swimming pool, you might have these. They come in about 4 feet long, 4.5 feet long, but they're hollow on the inside. And they're made of a nice soft rubber that keeps you afloat in your swimming pool in the summer. But these can also be cut down to any size, and you can slip a toothbrush handle into that as well. It doesn't give you as open of a grasp as the tennis ball solution, but it's a solution nonetheless. And this photo on the lower is basically a replacement bicycle handle, and that has been slipped over the toothbrush handle to give a better grip for the toothbrush for the patient. As far as floss, this is a 3-sided toothbrush, and you can see cross section wise, you've got a section that brushes the occlusal surface, but it also has 2 brushes that basically simultaneously brush buccal and lingual surfaces of teeth. This is really great for caregivers so that they can just do the scrub technique and brush all surfaces of the teeth at one time. It's come out very handy. Sometimes for our orthodontic patients that are having a really challenging time keeping their teeth clean, we'll try this as well. Obviously, these toothbrushes, again, are more expensive to order for the dental office and also for the patients to purchase themselves, but it is out there on the market for use. We also have floss aids. That keeps a little bit of floss and a longer handle. These are the shorter handle. We call these Dentapicks. So it's more or less the size of a toothpick, maybe about 3 to 4 inches long with a smaller slice of floss in there. These are great for either patients if they are able or our caregivers to use as well. I put the topic of oral rinses down there, and some of our special healthcare needs patients can't truly do a rinse by swishing themselves, but their caregiver or parent can actually dip the toothbrush into an oral rinse whether it be a gingival care product or a tooth or an anti-caries, anti-cavity mouth rinse. They can dip the toothbrush in there and brush the teeth with the rinse. Fluorides, there's multiple fluoride preparations out there. Lip care, especially for our patients that are more severely debilitated, you'll notice that their little lips are very dry and cracked. Petroleum products are not that great for drier lips, but lanolin-based products are the preferred lip care item for patients with special health care needs. Education can't be underestimated. We do need to realize that we need to take the time with all of our patients and teach them how to take care of their teeth, or their caregivers take care of the patient's teeth. Education can never be undervalued. It's a very important part of the patient experience. We know that also our patients that are more severely debilitated often have a gastrostomy tube or a G-tube in place, and that just allows the food to bypass the mouth and go straight into the stomach. That's great for caries risk because it makes our caries risk really low, but it does increase calculus formation. You're getting a high quality of food product with a lot of calcium, a lot of nutrients placed straight into the stomach, and that goes systemically through the body. The salivary glands pick out all of that calcium and deposit it right on top of the teeth. And you can see here is a very significant example of that a friend of mine saw when we were in New Orleans. She saw this patient at Children's Hospital in New Orleans, and you can see that the teeth are just caked in calculus or tartar formation, and she saw them in the OR and removed it. The OR operating room setting is often the safest place for these patients. Calculus is very porous, and microbes can enter those porosities. If that calculus is flaked off during a cleaning or even during bruxism, those flakes can go down and be aspirated into the lungs, and that can result in some serious issues for our young ones with manifesting an infection. There was an article back in 2006 talking about tartar-controlled toothpaste, and at the time I thought it was a very interesting article because I thought, well, you have to suction all the toothpaste out because they would use, you don't have to use that much toothpaste. It can actually be much simpler, but use a small amount of toothpaste on the teeth every day, and that will keep the calculus amount down from forming as much. That will also increase that length of time, hopefully, that we can take between taking our special needs patients to the operating room to remove all that calculus, if we can limit the severity of the calculus buildup at the start. Transitioning into our thought about orthodontics, and this was an interesting one to research, to be honest with you. The statistics are that 75% of patients with disabilities would benefit from orthodontic treatment. It's highly unlikely that we're going to do orthodontic treatment for 75% of our special needs population. But the beautiful part of that is the parents are usually very motivated. They are motivated by change, not only of occlusion, but they are more motivated by change of facial appearance. And they're willing to try whatever it takes in order to make their child or their adult fit into the population a little easier. They want normalcy within their patient, within their loved one. You have to consider the motivation. It's got to be very patient specific to discuss orthodontics with a family. You also have to be very honest and pragmatic. Don't be a hero. Don't look outside the box. Be very specific in your goals and theirs. We have to consider the motivation of the patient, their current oral hygiene status, because without good oral hygiene, it's really not wise to do orthodontics on a patient, any patient. Behavior. If they have to go to the operating room for any type of dental treatment, that is not a great case for orthodontics. And then their dexterity, who's going to care for the appliance, who's going to be in charge of things, that's the one that you'll be working with throughout the course of the orthodontic treatment. You have to have realistic treatment goals. They might be in the chair a little bit longer, so that goes into booking for the office as well. Just need to consider everything about that patient. If they have a heightened gag reflex, uncontrolled movements, muscular dystonia. If they have a poorly controlled seizure disorder, this is not a good idea and a good option for orthodontic care. But just plan early. If you have an orthodontist that you work with, obviously get them involved as well as far as treatment planning or implementing the treatment. Oftentimes with our special healthcare needs patients, we can just do some systematic extractions and guide the teeth into a more favorable occlusal harmony with just doing some extractions, which is going to be a lot easier than the child going through orthodontic treatment. But reasonable expectations are going to be what is the most important about having an orthodontic conversation with your particular special needs patients. And just some different conditions that we're going to see manifesting with oral maladies that could benefit from orthodontics. Intellectual or development delay, they are prone to an excess overjet or a class 2 presentation, cross bites, open bites. Down syndrome, there are fun ones that have a class 3 presentation, which we all know is more challenging from an orthodontic treatment standpoint. Cerebral palsy, which is one of the top special needs issues within Saudi Arabia, they manifest twice the number of malocclusions as does the general population, but theirs might be due to just the muscular dystonia, the fact that their muscles are kind of working on their own without being controlled by the mind of the patient, especially in the more severe cases. I found this picture from the 6th edition of the MacDonald and Avery textbook. I have not found it in any more contemporary edition of that text, but I love this photo. It's so basic, but it teaches us so much about what can exert forces upon a tooth. There are so many things besides an orthodontic bracket and wire that can exert forces on a tooth. Adjacent teeth, whether it be occlusally or adjacent or opposing the tooth, the alveolar bone is exerting a force on that tooth, but so much of the soft tissue is exerting a force on the tooth that over time is going to move things around. These are all affected by muscular dystonia. So even if you have a patient with cerebral palsy and you find them a good oral hygiene, parents are on board, patient is on board for orthodontic therapy, afterwards you might have some relapse just because those muscles cannot be trained. The teeth can be relocated, but the muscles cannot be trained. So again, that ties back to the realistic treatment planning and having those hard discussions with family members about what to expect, how to beat expectations, and if you can't meet expectations, what other paths you have to take. Autism spectrum disorder, they can manifest with many things that can be treated from orthodontic care, and depending on where your patient base is on that spectrum, the thought of orthodontics could be more promising. Asthma, we've heard of adenoid facies with our asthma patients, our severely asthmatic patients. Palatal vaulting, cross bites, they are really prime for orthodontic treatment. And should they not have any comorbidities, a pure patient with asthma is not a contraindication for orthodontics. Cystic fibrosis is a severe disease, but it's an interesting disease. With modern treatment and contemporary treatment, our patients are living a much longer and happier life, but their teeth can be very crowded, and from a social standpoint, a functional standpoint, they are very interested in orthodontic treatment. We do have to do some medical consultations because we don't want to give them any sedative that could interfere with their lung function. And also nitrous is going to have an effect on their lung tissue. So we need to be working in concert with their pediatrician or their general physician to see if that would even be an issue for them regarding orthodontic or dental treatment in general. One of the topics that is really gaining traction right now, and this kind of goes into orthodontics, but also a contemporary discussion of how special needs is playing a role in our dental practices, is the concept of obstructive sleep apnea. It is something that is becoming more to the forefront of continuing education topics, and also in the American Board of Pediatric Dentistry, the reference manual. We're beginning to see them addressing obstructive sleep apnea as well. It can really change just the tongue position within the oral cavity, can change the shape of the maxilla, crossbite, vertical growth, increased overjet, and open bite. So this is something that we need to screen for early on, and also figure out what course of treatment so that we can help in concert guide their growth and development. Etiologically, there's so many things that play into this, cerebral palsy being one, a lot of our dystrophies, GERD or regurgitative disease, any type of smoking that patients will partake of. Craniofacially, the maladies can be midface deficiency if they've corrected VPI with flaps, and then also our patients with Down syndrome. We know that they have a much shorter neck profile, a larger tongue, so they are more prone to having some type of sleep-related disorder or obstructive sleep apnea. And it was interesting to learn about the continuum from snoring to obstructive sleep apnea, and that continuum has the name of sleep-disordered breathing. We always screen our young ones before we do any type of sedation. We do some oral sedations here within our department, but we always screen them for snoring, and that tells us that they do have a vulnerable oropharynx, as far as it being much smaller than we would want for safety during a sedative procedure. Effects of sleep-disordered breathing: over time, it can lead to cardiovascular issues. It can actually alter the growth of the child because oxygenation is being influenced. They can have learning disabilities. They're not having restful sleep. They're going to be grouchy when they wake up. They're going to be a challenge when they're in the educational system. And that can manifest in learning issues and also just behavioral issues with our young ones. The American Dental Association back in 2017 came out with a statement that I paraphrased here, that sleep-disordered breathing is considered within the scope of practice of all dentists, pediatric dentists, all specialties. Therefore, we're required to screen for any disease or condition that falls within our scope of practice. So we do need to be incorporating screening activities for our patients with special healthcare needs, especially those that we have just discussed that could be of higher risk for obstructive sleep apnea. Orthodontic treatment may reduce snoring and obstructive sleep apnea by managing the sleep-disordered breathing. And some preliminary studies are showing, and now there's more contemporary evidence that we're getting, it's varied, but some of them are having some very positive effects of orthodontics and orthognathic surgery to compensate for obstructive sleep apnea. Some other issues, apart from just malaligned teeth, that we do need to be cognizant of is tooth wear. Especially our more severely debilitated patients are going to grind their teeth, but tooth wear, if it's possible to obtain study models safely, that would be the best way to track it over time, or photos and just check it over time. We also need to establish the cause. If it's gastric reflux disease, make sure that we make that referral over to a gastroenterologist for evaluation. We also need to check, obviously, for behavioral issues as far as young ones with eating disorders that could manifest in some tooth wear, typically behind the maxillary anterior teeth, typically. Bruxism, again, with our severely debilitated patients, they can really brux those little teeth down to the gum tissue, and amazingly, it is asymptomatic to them. It looks like it should just hurt, but it's asymptomatic. Again, photos or study models to monitor the progression. We want to also evaluate permanent teeth for wear facets. We all know that our children, one of the chief complaints of parents is that they are grinding their teeth at night and it wakes me up from sleep and it's so loud. Is there anything you can do for it? And I always encourage parents to have some patience with Mother Nature. Primary teeth, the explanation that I use for my parents is that primary teeth have a more bulbous cuspal shape. I probably don't use those terms when I'm talking to my patient parents, but with us, I feel like we can talk dentistry. So the morphology of a primary tooth, the cusp shapes are a lot more rounded, and they don't fit into those fossa of the opposing tooth very easily. So naturally, the tooth is trying to look for a connection, and so a primary dentition is going to grind their teeth. Permanent teeth have a more rigid cuspal anatomy that can find those fossa and grooves a bit more easily. And so once the permanent first molars erupt around the age of 6, I tell my patient parents, you know, hang on until the age of 6. Let's see if Mother Nature can reduce this on her own once the permanent teeth do come into a functional occlusion. So what I encourage the dental students, the residents, and practitioners to do, if you have bruxism and if you have wear facets on those primary teeth, always check the permanent teeth as they come into occlusion. If you begin seeing wear facets on permanent teeth, that is definitely an indication of a problem that needs to be addressed from a bruxism standpoint. With our severely debilitated patients, there is a theory that the bruxism, the act of bruxism, elicits an endorphin reflex, an endorphin release that soothes the patient. It gives them a sense of relief and pressure and pleasure. So oftentimes you will hear a patient bruxing just out of a sense of soothing, self-soothing. If the intensity increases, as all the caregivers will be aware of, that could indicate some type of pathology. It could be an earache, it could be some pain from even a non-dental source. It could be something as simple as an exfoliating tooth. If the patient is severely debilitated, it might be best for the caregiver to bring the child into the office for the safe removal and retrieval of an exfoliating tooth in a severely debilitated patient. Treatment ideas for the severely debilitated patient that bruxes is to do some full coverage with stainless steel crowns on the primary second molars to keep that vertical dimension of occlusion so that the face shape remains more vertical. Also, stainless steel crowns as needed with the permanent molars as they begin to erupt, or extractions if they're just if there's no hope for those teeth to be retained. Another issue is self-mutilation. More frequently is seen in our patients with special healthcare needs with developmental delay, psychiatric issues, traumatic brain injuries as from motor vehicle accidents, and in some syndromes, most often associated with the autism spectrum disorder. It's again a soothing, it releases the endorphins and it's a soothing thing for our young ones. Treatment, if they are using their arms and legs to do self-harm, you have to form some restraints. Occupational therapy might be of an advantage. Padding, just to make sure that they can't get to areas with their arms and hands. A lip bumper. We have some photos for you in just a second about lip bumper, occlusal bite appliances just to keep the teeth from inflicting any harm on the soft tissues. Acrylic splints sometimes are more stable in the lower arch. Botox has been used to paralyze the mandibular elevator muscles. Of course, that will render the patient in an open position, so now we have to worry about their mouth becoming dried out. We go back to our lip care, our soft tissue care. The lanolin-based products are the best for that as well, so stay away from petroleum-based products. I think it would be quite a challenge to inject the medial pterygoid, but that is one of the mandibular elevator muscles. That will not be in my wheelhouse of specialty to give Botox injections for that at this point in my career. Bite opening appliances, again, just to keep the lip and tongues from being impinged on the dentition. Sometimes, again, we have cases that are so severely debilitated, we have to think of doing extractions just for the patient's overall well-being. This is from an article I found from 2018. This is one of the bite opening appliances. It just keeps the teeth from coming together. The strap is nice and soft, and it's just used to basically secure the appliance for the child or adult patient around their head. And then you can see the cylindrical bite opening appliance that the teeth will rest on the top and the bottom of this appliance. And then it has the opening for continued airway availability. This on the right side is a picture of a lip bumper for our young ones that pull their lip up and over their teeth and then bite down to inflict self-harm. The lip bumper just keeps that lip from being able to be impinged between the teeth and the dentition. Interestingly enough, though, you will have to do an impression, fit bands. This is a challenging appliance to make. It often involves either a trip to a procedural surgical center or some form of sedation in order to safely acquire that particular impression for that appliance. Pardon me, I'm going to take a sip real quick. Getting dried out. Apparently, I'm talking too much. These are just some examples of the mouth guards that are used with our young ones, like Lesch-Nyhan syndrome, where they do a lot of self-harm. This young one had been biting their tongue repeatedly with their dentition, so they made a fairly rigid lower splint. The upper is just a thin thermoplastic material, similar to what we make the Essex appliance retainers with. They did put some little composite buttons up on the maxillary dentition just for retention of that particular device, but that was what that this particular study looked at to try to help this young one not injure themselves so often. We're going to finish up with some contemporary discussions of some comorbidities that we do need to be aware of as we work with our patients with special healthcare needs. One that has really come to the forefront recently is the methylene tetrahydrofolate reductase deficiency. That decreases the methylation within the cells. Methylation is necessary. It's the trash remover of the cell. It leads to cellular repair. Our immune system functions better. So basically, we need this system in place and not disjoined, if you will, for cellular activity to continue in a healthy way. Interestingly, this deficiency affects 20 to 40% of population, depending on where the patient is. There has been shown to be a link with autism spectrum disorder in one of the articles that I read as well. In our patient base, I have not seen a particular link, but I'm going to start looking now for autism spectrum and the MTHFR deficiency. There are some genetic variants, but what we need to be cognizant of is patients with this particular issue, we don't need to use nitrous oxide with this patient base. It will inactivate the B12 within the methylation cycle, so therefore methylation cannot continue. So the toxins within the cells are not flushed out of the cells, and the cells become very toxic. Cells die, and that leads to a very ill patient. So screening your patients for the MTHFR deficiency enzyme is key, and they will know if they have it, typically. A second comorbidity that is actually coming back to the mainstay now, we haven't talked about scurvy for such a long time. We talked about scurvy with sea travelers long ago, extended periods on a ship where they had to be cognizant of the foodstuffs they were bringing aboard that would spoil over time. And so the sailors and the patrons were not receiving vitamin C. Vitamin C is an antioxidant. Again, it helps with cellular health. But with our special healthcare needs patient base, there's a link with autism spectrum disorder and any special healthcare needs that are on a limited diet. Sometimes it's self-induced because of food preferences or textural aversions. But you can see that there's a severe effect within the gingiva, very exophytic, hemorrhagic, just not pretty gingiva. And then there's an interesting effect called keratosis pilaris, and all the little hair cells, so all of our little hair cells on our appendages become inflamed with a little red papule that you can see here. I will share with you, this was one of the patients that we saw when I was in South Carolina, and it was an interesting case that we had taken this young one to the OR setting, operating room, 6 months earlier, and had done some restorations for him. Teeth A and B, so on the upper right-hand side, his primary first and second molar, both were restored with stainless steel crowns. No pulpal involvement, but just stainless steel crowns. He came for his post-op. Everything looked fine. The gingiva was healthy. All of his restorations were intact. He presented for, I think it was a recare about 6 months later. Everything looked fine. Everything was intact. And within a month's time, Mom called for an emergency appointment. The young one came in, and this was a photograph after we had actually had to remove teeth A and B with their stainless steel crowns. But the teeth had become infected, but the gingiva over 2 weeks' time did not respond to therapy, or the fact that we took the teeth out of the way. At the time, this was the only area of gingiva that looked abnormal the day of the extraction. He came back post-operatively. Lesion is still there, and now various other areas of his mouth have these red, just fiery red, friable gingival tissues. You can see we don't have good oral health care. This is actually a graham cracker that he had been eating, and so we started talking with Mom about his diet and brushing and what he eats. Mom says, oh, he's very picky. He eats graham crackers and chicken nuggets. And that was what this young one was subsisting on, because he had textural aversions, food aversions. He had a combination of Down syndrome, as with combined back to autism spectrum disorder. So he was debilitated. When I first met him, he could walk on his own, but as the treatment progressed and into this particular presentation, Mom was bringing the young one in a stroller. And he, pardon me, as you can see by his dentition, he was at least 6 years old when we were seeing him, as his permanent molar has erupted here. Actually, the child was 8. So it's just an interesting case to try to figure out. I worked with Dr. Brad Neville. He's a preeminent pathologist, and he's still at the Medical University of South Carolina. And we decided to see if it was scurvy, and looked up some articles, and it was starting to be reported in the literature. Referred the young one to nutritional specialists, and you can see with diet modification, this was the lesion prior. The premolars have begun to erupt, but you can appreciate, hopefully, that his gingival condition is actually much improved. This was just from gingival irritation from the mouth prop that we had used to observe everything. His catarrhus pilaris has actually resolved, and what you see here are his cute little freckles on his thigh. So looked much better. He actually was still in the stroller, but he was able to stand on his own and take a few steps. And it was really interesting to see this progression of disease severity take over, but then how rapidly his body recovered with some therapy as simple as getting some vitamin C on board. But Mom was really good about working with him, and you can also note that his healthcare, self-care is doing much better with Mom brushing a lot better too, because his gums aren't bleeding anymore. So she was so petrified and scared about his gums bleeding with the tissues when she put the toothbrush in there. So this was just a happy story I wanted to share about something that I don't know if you're seeing it where you are, but every once in a while with our special healthcare needs patients. And I just saw an article that was recently published by some dear colleagues. They did a fantastic literature review on scurvy or vitamin C deficiency within our special needs and healthy population as well. So that's an interesting article. Keep your eye out for that. Other comorbidities, we have to mention it. It's what we're dealing with right now, the disease of COVID-19, which is caused by the virus SARS-CoV-2. Here in America, we're seeing the multisystem inflammatory syndrome in children. I have not seen that specifically here in the state of Virginia, but I know that we have cases, and the cases are on the rise in several of the states within the United States. This virus gets into the salivary glands, and it gets into the saliva. So even during non-aerosolizing procedures, if we have a non-symptomatic, asymptomatic patient that has the virus within their oral cavity or within their salivary glands, we have to take precautions, use our high-vac suction, keep everyone physically distanced. If you don't have to have families in the room, we were having a conversation just prior to our session tonight, and about how we've had to change things within our department and within our offices to accommodate the families, but at the same time we have to keep them out of the operatories with their child patients that's undergoing treatment. But another interesting thing that is an issue for especially our adolescent and our young adult patients, the sharing of smoking instruments, whether they be electronic cigarettes, water pipes, the virus can again be transmitted in that fashion. And we have to do some anticipatory guidance with our patient base, make sure that they understand, to be very cognizant of that. We know that one of the signs of COVID is altered taste or lack of taste with dysgeusia. They just can't taste anything. Another sign is burning mouth, which we often attribute to our older population, or a population that is being treated for some blood dyscrasias with chemotherapy. This virus also uses the ACE2 receptor, the angiotensin converting enzyme 2 receptor. That is how the virus gets into the cells. But interestingly, that particular receptor is also located in conjunctival mucosa around the eye, and even in the nasolacrimal duct, which goes into the nasopharynx. So this is something we really have to watch out for. Be cognizant in your offices. Make sure that you're taking the precautions that we need to protect ourselves, our staff, our families, and our patient base as well. And just some final thoughts for your area in specific. There's been increases in hypertension, diabetes. All those things are going to manifest in, we're seeing it even here in our younger patients. Hypertension used to be something we would be worried with our older adult patients, but we're seeing a rise in hypertension even within our child patient base. Rehabilitation centers are increasing in number. I read one of the articles that was saying that they're taking great strides to increase the number of rehab centers that are open for patients, special ed services through the Ministry of Health, and then the legislation of disability, which was passed in 2000, stating that persons with disabilities have access to free and appropriate medical and psychological, social, educational, and rehabilitation services through public agencies. And I think it's fabulous that the country is taking that step, and hopefully it's being utilized. And one of our roles is education of our patient base, and just to make sure that they understand what the outlets are, what their opportunities are, what services are available to them, and almost be that conduit to try to help them come up with a care plan for their particular family member that's affected by a special healthcare need. And I just wanted to make sure that you all saw another little image from Texas. This is actually near where I most recently moved from, out of Texas, near Austin, which is the capital of the state of Texas. I think it looks more like Hawaii, so I was always excited to be able to go to Hamilton Pool and kind of take myself away from my my day-to-day activities, kind of venture out to what I thought was paradise. But hopefully we were able to have a discussion tonight that will help us kind of redefine our ideas of how we're going to work with our patients, reconsider some different care approaches within our special healthcare needs patient base, and just give us a new vision of what we can do to help our special needs patients. I really appreciate the opportunity. Thank you again for your time. And I look forward to hearing some comments and working through some questions with the group. Thank you so much.
Thank you, Dr. Patterson, for your excellent, informative, knowledgeable lecture. I really enjoy it, and I gain a lot of knowledge and information. Thank you so much. So we'll open the discussion now for several questions we have. So we have the question here. That person is asking, what is the management consideration for acute changes following chemotherapy, radiotherapy, and the stem cell transplantation? And how can it affect children's quality of life?
Acute changes with chemo and other cancer therapies with the young ones. That is variable as well. Their gingiva is going to be more friable. Obviously, their caries risk could go up just because it's such a challenge to brush for our young ones when they have sore gum tissues. I think that one thing we need to work with is the little toothettes, which I wish I'd put a picture of the toothette in here, but that can often help. It's basically, it looks like a little foam lollipop on a stick, like a little foam lollipop. With a little stick to it, and those are super soft. You can dip them in either a fluoride anti-cavity rinse, maybe like a gingival preparation if necessary. We do have to watch for staining with some of the gingival care preparations, and just working with their primary care provider to make sure that we're all on the same page about where their treatment is going, how long they're going to be affected by their particular condition, how long their chemotherapy or radiation treatments are going to be lasting, diet modifications if necessary to reduce like spicy, salty, spicy foods that could really irritate the gingival tissues. And I'm not sure if I'm touching on specifically what the inquiry is for, but that is a challenge for especially a really young patient that doesn't have the cognitive approach to know what they're experiencing. It's a challenge for sure.
Okay, for
and
sure.
Stay away from toothpaste that contain pyrophosphates, tartar-controlled toothpaste. Just the word pyro in the name of pyrophosphate, which is the active ingredient in a tartar-controlled toothpaste. That's what keeps the tartar down. But pyro means fire, and so that's what their gingiva is going to feel, is hot and spicy from that preparation. Mm-hmm. So I would stay with just a fluoride gel, neutral sodium fluoride gel for that patient base.
Okay, very good. We have another question. Someone is asking, which type of mouthwash do you think is more effective for rinsing for special healthcare needs patient?
That depends on the ability of the patient. If they can self-rinse, an anti-caries mouthwash is great. If their caries risk at present is low, the over-the-counter products, which have about 0.12% fluoride solution, those are okay. They can even dip their toothbrush in and brush if they need to. As far as swishing, as we would use mouthwash, that is going to be very dependent on the patient's abilities. If they need more, if their gingiva is in more bad shape than the teeth, if we don't have a caries risk, but we have a gingival condition that needs to be addressed, then your Paradexes, Parameds, anything alcohol-free, and they have several on the market that are alcohol-free that won't damage the soft tissues as well. PerioGuard, Colgate, I think Gum brand has several products out there, so a good literature or a good Google search will help with that as well. But again, it depends on if the patient is able to do the swishing themselves or if they need the product to be brushed on. And anything liquid can be brushed on with a toothbrush.
Okay. Another question. Someone is asking about the mode of action of tartar control toothpaste with the branding, the one that you prefer to use with the special healthcare needs patient.
Brand-wise, I don't know that there is a particular one, and I'm not going to advocate a product because that's not what I do. But as we just talked about, tartar-controlled toothpaste do have a chemical in them called pyrophosphate, and that is what disrupts that disconnecting barrier between the calculus formation, the plaque actually first, and the tooth, and that's what keeps the calculus count low.
Okay.
But it is, by the name pyro, it's going to be warm, it's going to be hot to the gingiva.
Okay. Thank you, Dr. Patterson. So what about the cooperation level of special healthcare needs during orthodontic treatment? What are your suggestions in the behavior guidance when you do ortho treatment for special healthcare needs? I think this is what he means.
Okay. I'm a very conservative when it comes to discussing and offering orthodontic care for special healthcare needs patients. If I am working with a severely debilitated patient, those are some of the more challenging conversations to have with parents, because if I need to do any type of sedation or go to general anesthesia for orthodontic care, I'm not comfortable in rendering care that way, because my thought is, if the child can't manage their own personal behavior to have an impression made, a band fitted, wires adjusted, they're not going to be a good candidate for not only orthodontics, but their home care is going to be a problem as well. I typically am, like I said, very conservative with my personal approach to orthodontics with special healthcare needs, but I felt that it was worth having that conversation just to even put it on the table of discussion for our patient base with special healthcare needs. Patients with asthma, that's their only issue with no other comorbidities. I know I'm repeating myself from the discussion a little bit too. Autism spectrum that are on the more docile end of the spectrum, those would probably be the ones that I would work with for orthodontic care in my hands. I'm sure there are many more experts out there that could do something much better than I.
Okay, someone asking even about the hearing impairment or disabled patient during orthodontic treatment. How do you communicate with them? How do you motivate them to be more cooperative during ortho treatment?
And sometimes that's just a product of the fact that they don't understand what we're attempting to accomplish. I know that there's some things in the literature about working with visually and hearing impaired patients. Oftentimes for hearing impaired, if they don't have a cochlear device, trying to find a translator, I don't have the capabilities for sign language, but we do have sign language facilitators within the educational system here at VCU. That's a challenge, but I think that for that particular patient base, coming from academics, we have residents and dental students, which makes it a challenge for continuity of care sometimes. I think in that case, to motivate someone with hearing impairment or visual impairment to at least keep them with that same provider, even in a multi-doctor practice, to keep them with that same provider so that they can build up a rapport and an understanding about that provider, and they don't have to keep changing how they are delivering information to the patient, that they're doing the same thing consistently at every visit.
Mm-hmm. Okay, doctor. So somebody is asking about the three-sided brush, the name of the three-sided brush, so they can request it for their patient.
I would have to Google the name of the three-sided brush. I know that we have them here. I don't know what brand we use. I think there are several out there on the market, but I'm more than happy to send you that information afterwards. I'll come up with a list.
Please. Somebody is not convinced about how G-tube fit patients will develop calculus in their mouth, although they are not eating. So how do you give them just a short explanation about the mechanism, how it happened?
Again, I'll be somewhat repeating myself, but the way I was explained by my mentor in my residency was that even though they're not being fed by mouth, the quality of the food product that is being delivered straight to the stomach has a high amount of nutritional value for these patients. So it's going to have high calcium, high phosphorus, and calcium is a critical component of calculus. Once the calcium gets into the stomach, it gets dispersed into the bloodstream. The bloodstream carries the calcium into the salivary glands, or into the glands themselves, which excrete it via the salivary ducts. And that's how, you know, we always see our patients that have the buccal calculus on the maxillary molars and then the lingual calculus on the lower anteriors. That's where the salivary glands deposit their saliva, because we've got parotid here, and then we have the sublingual right behind the lower anteriors. And so just over time, that development can totally encase the teeth, like we saw from Dr. Ritwick's pic photos. It's a stunning photo. But
Okay,
that was what I was taught. I don't know if I've reconvinced them, but that was what I was taught, and I believe my mentor.
Very convinced and interesting too. So another one is asking, is there OSA questionnaire? I think he meant the obstructive sleep apnea questionnaire that we can use to screen pediatric patients in a systematic manner.
And I know that through my work with the Council on Scientific Affairs with the AAPD, we're developing something like that, and I think, is it ENTs that already have something out there about obstructive sleep apnea? And again, I can always send that link as well, but I think that the AAPD definitely endorses any type of a screening tool for obstructive sleep apnea. And I'll just have to look up the specific reference and get it to you.
Okay, so someone also asking you, please, if you can share the articles that you posted in your lecture, so they can go and search for them. And also they were asking about the contraindications of, I think, nitrous oxide sedation. They are asking, are they only cystic fibrosis and methylene deficiency, or there are other contraindications in special healthcare needs patients for the use of nitrous oxide?
There are other conditions. Off the top of my head, sickle cell disease. Sickle cell disease, of course, that is an issue with transporting oxygen within the red blood cell, and pardon me, but the red blood cell is defective and it can't carry as much oxygen, and so use of nitrous oxide in those particular patients needs to be reviewed with their physician to see if it would be contraindicated in that position, in that patient base. Sickle cell disease, there's also sickle cell trait. Typically, they don't have a cross reaction with nitrous. Their blood cells are working appropriately, but they are just a carrier for the disease with another person. Sickle cell disease, cystic fibrosis. Right off the top of my head, those are the ones that I'm coming up with. Anybody that's undergoing chemotherapy, radiation treatments, and there's probably more. I just can't think of them off the top of my head right now.
Okay, it's fine. It's fine, doctor. So somebody is asking also about, do you prefer to use bovidine iodine or chlorhexidine mouth rinse for a special healthcare needs patient?
I love the thought of povidone iodine. I've done some literature review on that particular liquid. I really like what it's showing that it can do. Presently here in America, I don't think povidone iodine is as practiced as is chlorhexidine. So here in our clinic, we do have chlorhexidine at our disposal, but there's some really good research and really good information out there about povidone iodine. I think that would be useful, especially in, I think it's more financially achievable than chlorhexidine would be.
Okay, very nice. So somebody is asking also about the general treatment protocol that you follow for autistic spectrum disorders, patients with autism or Asperger syndrome, for example. So what's your general protocol?
General protocol is I try to have just the patient and their caregiver in the room with myself and the assistant, or the resident and the assistant, limiting distractions. It depends on where they are on the spectrum. Sometimes they can do, I think, I forgot what the little booklet is called, but it's almost like a little guide that systematically takes them through an appointment. We can do some techniques where they come into the office and get acclimated to the office without dental care happening to desensitize the patient. And that can be anywhere from 1 visit up until 3 or 4 or 5 or more to finally get them either into the chair or into an area where we can actually conduct an exam. Sometimes we have to do exams out in the waiting room, and we will take our mirrors and go out into the waiting room and do our exams. It just really, it's patient specific for sure.
We still have a lot of the questions, Dr. Patterson. Somebody are asking about the orthodontic treatment for Down syndrome, for example, and others asking about the general treatment for hemophilic patient in your clinic. So can you just highlight about this and this?
I told you it was a wide spectrum when we started talking about special needs. It could go in a lot of different tangents. And hemophilia, that is one where I definitely am going to consult with a primary physician to figure out what protocol that they're on, if they need to supplement before they have any dental treatment, whether it be a prophy or an extraction, what level of supplementation, and that's all driven by the primary care provider. Was it autism? No, Down syndrome orthodontics.
Down syndrome, yeah.
It depends on the spectrum, how cognizant the patient is, what their cognitive ability is. Again, with the muscular dystonia, you've got a huge tongue, a very powerful, huge tongue. You've got that class 3, which typically is only going to be treated by surgery as the patient stops growing. Face mask, maybe. Just depend. It's very patient dependent on that. But I don't do that much orthodontics, and I probably myself would not tackle orthodontics with a Down syndrome patient. I'm going to leave that to the experts. I told y'all I was not an expert when I started tonight.
I agree with you. I totally agree. So what about the laser therapy in healing of soft tissue? Do you use laser more frequently in pediatric dentistry, and for which condition specifically?
I don't know about more frequently. I'm actually going to have to plug my phone in. My apologies. So you're going to see my big hand right now. Let me get you plugged in. I think that's plugged in now. I hope it is. We shall see. If we get disconnected, you'll know why. May I have the question again?
What about the laser therapy?
Laser
healing
therapy
of soft tissue in pediatric dentistry.
When I was in private practice about 11 years before I went into academics, and I used a hard and soft tissue laser in my own practice. Here at VCU, we have a hard and soft tissue laser available. At MUSC, we had a soft tissue laser. There's obviously various different kinds of lasers. And as far as soft tissue healing, I have seen some not only from a soft tissue healing standpoint, but a wound healing standpoint. Let's say if we excise a mucocele or have to do some type of frental procedure, the laser therapy has shown a really good success with tissue healing, less discomfort post-operatively. We just had a little fellow in earlier this week in the dental clinic that had a frenectomy back in February. And I looked at the tissue and it looked really nice. So of course it's been 6 months, but I think that laser therapy in the future is going to be, the direction is fascinating to me. So I think it's going to be an interesting piece of our armamentarium.
I agree with that. So, Dr. Patterson, do you think, or do you use silverdamine more frequently with a special healthcare needs patient? Just to overcome the waiting list for the OR?
To overcome waiting lists, to buy a lot of time, and that's something that I didn't put in the discussion. I guess just because I thought maybe we needed to talk about silverdamine fluoride in and of itself. It is a great tool to have, especially with our special needs patients, to buy us time to get to the OR. I think I finally plugged you in. I think I did. To buy us time to get to the OR, but also just in treatment in and of itself. With young ones or with very superficial caries that are not to the DEJ, or right at the DJ. Sometimes the silverdimine can actually buy us quite a bit of time, maybe even to exfoliation, depending on the age of the child. So silverdimine fluoride, I think, has a great role in special needs dentistry. And my apologies for not including that. I guess I felt that it was, I don't know, too global, but perhaps it's not yet. So I'll need to keep that in mind for next time.
Okay, one more question. We still have a lot of questions, so I think maybe we send them to you and you can discuss them later on. So one more question. Someone is asking, can I use nitrous oxide with cardiac patient? Is it
with a COVID patient?
Cardiac patient.
Cardiac
patient, yeah.
It depends on the condition. If their output is compromised, I would run that through their primary healthcare provider. I mean, if they have like tetralogy of Fallot, typically once they have surgeries and they're back to a fully functional, there's no contraindication, but it just depends on where that child is within their treatment protocol. So I'll refer that to the primary physician and see if they have any particular limitations. But typically with cardiac patients, unless there is another comorbidity or if they're not all the way through their treatment protocol, it's not, I'm not going to say it's never contraindicated, but it's typically not contraindicated once they're on the other side of their treatment protocol.
Okay, and also we have to do consultation.
I don't know what specific, all the time consults, and I don't know. Yeah, I didn't know which particular cardiac issue they were discussing. So again, we're on a spectrum when we're talking about cardiac issues, a broad spectrum.
Of course, yeah, of course. So at the end of this lecture, on the behalf of the Saudi Society of Pediatric Dentistry, I would like to thank you, Dr. Patterson, for your time, for accepting this invitation tonight, for sharing your knowledge and experience about special healthcare needs. Thank you so much. It was very enjoyable, informative, knowledgeable lecture. Thank you so much. Yes, so thank you, Dr. Patterson. This is a certificate of appreciation from the SSPD for your valuable contribution tonight to this excellent activity, and hopefully in the future you can join us again in the new activity. Thank you so much from Virginia. Thank you so much. We miss you all there. Thank you.
Appreciate it.
So thank you everyone for all the attendees tonight. I would like to invite you for next activities that we're gonna announce in the near future on the website of the Saudi Society of Pediatric Dentistry. So hopefully you enjoy it, and it was very informative lecture for you all guys. Thank you so much and have a good night. Bye-bye.